Broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to the Children's Cardiomyopathy Foundation's webinar on developments in research and treatments in pediatric cardiomyopathy. We are glad that you're joining us this evening, and we hope that you find the presentation to be very informative and helpful. Before I turn the presentation over to our guest presenter, Dr. Towbin, we just have a few housekeeping notes. If at any point during the presentation you need technical assistance, please type your concern in the chat window, which is on the right-hand side of your screen. You have a control panel, and there are different tabs there, and you can choose the chat box at the very bottom. And if you have any audio issues, you can switch between your computer speakers as well as calling in by phone under the audio box. In order to provide the highest quality session today and to avoid background noises, all attendees are in listen-only mode and will be muted for the presentation. Your questions are encouraged and welcome during the presentation. Your questions can be submitted by the question box located on your control panel. And we'll be taking questions during the last 15 minutes or so of the talk. So please feel free to type your questions in throughout the presentation as you think of them, and then at the end they'll be addressed at the conclusion of the presentation. And we will also be recording this webinar and posting it on our online website, so you will be able to access the information at a later date. And now I'd like to introduce our presenter. Dr. Jeffrey Towbin is co-director of the Heart Institute at Bonheur Children's Hospital, chief of cardiology at St. Jude's Children's Research Hospital, and professor and chief of pediatric cardiology at the University of Tennessee Health Sciences Center. From 2003 to 2009, he served as Chief of Cardiology at Texas Children's Hospital and served as co-director of the Heart Institute and Chief of Cardiology at Cincinnati Children's Hospital Medical Center from 2009 to 2015. Clinically, Dr. Towbin has focused on cardiomyopathies and heart failure, cardiac transplantation, and cardiovascular genetics as his areas of expertise for his entire career. He has trained many of the leaders in these fields. Dr. Towbin's research has focused on the genetics and mechanisms of cardiomyopathy and advanced heart failure, arrhythmias, as well as on inflammatory heart disease. His research has been funded continuously since 1987, and he has trained more than 50 postdoctoral and 20 predoctoral students, many of whom now have high-level academic faculty positions. His laboratory research team has been a leader for many years in the field of gene discovery and mechanisms of these disorders, as well as viral causes of inflammatory heart disease, including transplant rejection and transplant coronary disease. He has co-authored more than 500 publications in high-impact journals, served as a principal mentor for multiple Kate Grant-funded trainees, and has been a member of multiple T32 training grants. In 2007, he received the American College of Cardiology Distinguished Scientist Award, and in 2013, he was awarded the American Heart Association's Basic Research Prize. Without further ado, here's Dr. Towbin. We are just thrilled to have you with us today, Dr. Towbin, and thank you for joining us. I'm going to switch over the screen to you now.
Thanks, Gina.
Thank you.
I'm not seeing anything pop up.
I can see your screen. If you want to just open the PowerPoint. Yep, we can see our PowerPoint now.
Okay,
we're all
terrific.
set. Thank you.
All right. Well, thanks for joining everyone on this lovely evening. What I'm going to be talking about tonight is pediatric cardiomyopathies, clinical care, research, and future therapies, some of which are already being at least tested as possibilities. So why don't we now get started? So the first question, obviously, is what is pediatric cardiomyopathy? It's, we need to make sure that our definitions are clear. Because it's not one entity and one entity alone that we're talking about. So the way I like to look at pediatric cardiomyopathies, whether or not they're associated with heart failure or they're not associated with heart failure, They look different. They may or may not have different genetic basis or acquired forms. And so I like to bring them down into how they work or don't work. And so I split them up here into two subgroups. The top one, systolic dysfunction disorders. Systolic dysfunction talks about squeezing of the heart. So when the heart squeezes, that's systole, so systolic function. And when the heart relaxes, it's diastole or diastolic function. And so if the squeezing is poor, as in dilated cardiomyopathy, for instance, we would call that systolic dysfunction. If, on the other hand, you had a heart that was stiff, that would be diastolic dysfunction. The classic disorder that would be diastolic disorder would be hypertrophic cardiomyopathy. So the systolic dysfunction disorders include dilated cardiomyopathy, DCM, arrhythmogenic cardiomyopathy, which used to be called arrhythmogenic right ventricular dysplasia or cardiomyopathy. Now we know it's both ventricles. Left ventricular non-compaction, the newest kid on the block, and that has overlap, can be a systolic function disorder or a diastolic function disorder, and I'll get into more about that later. And then finally, end-stage hypertrophic cardiomyopathy, where it goes from being a diastolic only problem to a combination problem. The stiff hearts, the ones that have diastolic dysfunction and don't relax well, would be hypertrophic cardiomyopathy, would be the classic, restrictive cardiomyopathy, and then again, some forms of non-compaction. So that's the grouping that we'll be talking about this evening.
Dr. Towbin, I'm so sorry to jump in. Is it possible to maximize your window, because the top part of it is getting a little cut off on the PowerPoint? So, like, are you able to enlarge it a little bit? I'm not sure if that's the problem, where part of it is getting cut off at the top, but not a huge deal.
Oh, it looks fine on my screen.
Okay.
I don't see.
Okay.
I don't think so.
Okay. No, that's okay. Sorry.
No problem. So this is a collage of echocardiograms looking at exactly the same view for the different disorders associated with or classified as cardiomyopathies. This first one here on the far left at the top is dilated cardiomyopathy. And what I'm showing you here is the head would be up here, the feet would be at the bottom. So this is an upright heart. This is the left side of the heart. So the left ventricle at the bottom, the left atrium at the top, collecting chamber, pumping chamber, and then the right side of the heart is out of the picture. But this ventricle is too big and in motion doesn't squeeze very well. Classic features of dilated cardiomyopathy. Hypertrophic cardiomyopathy right next to it is the opposite. It is very thick. It has a very small chamber because it's taken up by muscle. And you can see the atria on top. This would be the left atrium, the right atrium, and the right ventricle you can see is small also because this big thick wall in between the two ventricles, the interventricular septum, is taking up space on both sides. Classic hypertrophic cardiomyopathy. Restrictive cardiomyopathy, another diastolic function disorder like hypertrophic cardiomyopathy, is very stiff, but is classically has no associated thickening or hypertrophy. But in this case, the atria are very large. In fact, they're commonly bigger than the size of the ventricles, and you can see on the dilated and hypertrophic forms that the ventricles are always much bigger than the atria, but not the case with restrictive cardiomyopathy. Left ventricular non-compaction, on the left ventricle here, there's this stuff that look like individual fingers of heart muscle that go all the way down to the bottom or the apex of the ventricle. And these are called trabeculations. So this would be a hypertrabeculated left ventricle. It's supposed to be very smooth wall like you see up here with dilated cardiomyopathy, very smooth. There's no extra stuff there This is just filled with trabeculations. This is non-compaction. And then finally, arrhythmogenic cardiomyopathy over here on the far right at the bottom, where the right ventricle is dilated. It looks accordioned out here and down at the bottom. It's very thin-walled on the right side of the heart, and it's replaced with fat and scar tissue in the ventricle where the heart muscle should be, and so they have arrhythmias associated with it. So those are the 5 classified forms of cardiomyopathy, and that's what we'll be talking about for the remainder. So let's start with the definition: dilated cardiomyopathy. Dilated means enlarged. Cardio is heart. Myopathy is muscle. So an enlarged heart muscle disease. And that's all you could get out of what dilated cardiomyopathy is, and it's a reasonable term. How common is it? Well, the annual incidence is about 1.1 per 100,000 children, but it depends on how old you are. So it's much more common in babies less than a year of age, about 8-fold more common, 8.3 versus 0.7 in the early age range, in the later age range, and that compares to about 8 per 100,000 in adults. So about the same in the babies as adults, but a high prevalence in adults because of coronary heart disease, which we don't see in pediatrics, fortunately. These are individuals that have systolic dysfunction, so the squeezing of the heart is depressed. They may have associated stiffening of the heart, but the primary problem is the pump just doesn't squeeze very well. They may or may not have rhythm abnormalities, too fast or too slow, and this is where you get your symptoms from. The poor pump function leads to heart failure, so fluid can't get out of the heart appropriately. It backs up at the top chambers. It can't get pushed out of the bottom chambers very well. So it then backs up in the lungs. You have trouble breathing. So you get breathlessness, you get exercise intolerance, you have a poor appetite, you may get belly pain, you sweat inappropriately, you can't sleep because you can't lay back and breathe very well. You may get swelling in your legs and your abdomen. These are classic features of heart failure. Some cases may be acquired, and in pediatrics, it's usually a virus infecting your heart, so we call that myocarditis. Or you can have other reasons, like if you have cancer chemotherapy, for instance, it poisons the heart muscle and you can get a dilated cardiomyopathy. But the typical reason in pediatric patients is genetic, so an inherited form of disease, or chromosomal disorders or syndromes, all genetic-based abnormalities. So genetic-based disease, more common in kids, less acquired forms of disease than in adults who overwhelmingly have coronary heart disease, which is an acquired problem. So this is what the heart would look like in comparison to normal. Here would be the normal heart, normal ventricle size, which is about the same in the right ventricle as in the left ventricle. The atria up here, this atrium and left atrium up here is not very large. And you'll see a difference in that when we get to some of the other cardiomyopathies versus the dilated cardiomyopathy, where you can see the chamber is much bigger than the normal heart, and you see some thinning out down at the bottom of the ventricle here of the heart wall because of the dilation of the ventricle. It's like blowing up a balloon too large, where you get thinner walls and more chamber dimension, if you will. And the more chamber dimension is so that it holds more blood in the heart, so that it could ultimately pump out enough blood to the body so the body can do whatever the body needs to do. So that would be what you should have in your mind when somebody says dilated cardiomyopathy, a big left ventricle, and it doesn't squeeze very well. So if we were to do an evaluation of an individual who we think might have dilated cardiomyopathy, maybe presenting to the emergency room, This is a chest x-ray. This heart is very large. It takes up the whole chest. It should take up much less than 50% of the chest, and this is taking up about 80 or 90% of chest. So you know you have a big ventricle there. We call that that heart that's very big. We call that cardiomegaly, cardio heart, megaly big. So an enlarged heart. This is an echocardiogram laying on its side. This is the left ventricle here. It's too big, and this individual has extra fluid outside the heart. We call that an effusion, a pericardial effusion, fairly common in dilated cardiomyopathy patients. And the rest just shows that the squeezing is not very good. Typical features of dilated cardiomyopathy. And so that would be your diagnostic testing to make the diagnosis of dilated cardiomyopathy. So how do you get there? Well, if you have a genetic abnormality, so a genetic abnormality in a gene, what that does is the genes are there to make proteins ultimately. Then the proteins are the things that actually do the work of the heart. And so if you have an abnormality in the gene, it makes the proteins that it's supposed to create weaker than they ought to be. And so the heart is beating some number of times per minute. Little babies, it may be beating at 150 times a minute. That's a lot of stress on the heart muscle. The blood pressure is probably going to be 80 over something. And so the heart, you're asking to work fast and to pump hard against a pressure of about 80 millimeters of mercury, which, if depending on which proteins in the heart are abnormal and fragile, can get beaten up pretty quickly. And over time, with mechanical stress on each heartbeat, it's just going to give up. And so it dilates and is allowed then to have more blood in the chamber because the pump doesn't work very well. So it was beating fast in the first place, so there were more heartbeats per minute to pump out the blood. And when it couldn't do it, it just started getting faster and faster until it got to a point where it ran out of the ability to go any faster. And so then it starts dilating up to have more blood in it. So faster and more blood, you can, over the same 1 minute, put out the right amount of blood that the body needs. But ultimately, the heart doesn't squeeze well enough and that blood doesn't go anywhere, and it just backs up into the lungs and you get the heart failure symptoms that I mentioned a minute ago. So that's how this all happens, from a simple abnormality in a gene that causes a problem in a protein that is a critical protein to the squeezing or relaxing of the heart. There are a lot of genes that cause these diseases, but really there are only a few that take up the vast majority. And depending on which form of cardiomyopathy we talk about, some of the predominant genes will be easily tested by genetic testing, and it'll be a robust and good test. And for other diseases, it's not a great test. So lots of genes, probably over 50 or 60, that have been identified as causes of dilated cardiomyopathy, although probably some of them are not real causes because there's just not enough evidence. But there are some that are pretty common. Lamin AC, for instance, would be one of them. Myosin binding protein and myosin heavy chain would be others. And there are a few others in here that are relatively common, and I'll show you that momentarily. But this, from a genetic testing perspective, there's too many genes that are not found in enough patients to really be a great genetic test. And so with dilated cardiomyopathy, if we send a test out, we're going to get about 30, maybe 40% of the patients properly diagnosed genetically. So not a terrific test, but still working on to make it better. But at the end of the day, when you go back to what those genes performance is, what the proteins are, this is a single heart muscle cell that I've made this illustration of. This is the so-called cell membrane. This is the inside of the heart muscle cell. This here is called the sarcomere. This is the contractile apparatus of the heart, meaning it makes it squeeze and relax. Think of it as a gate, if you will, where the gate, when it shuts, when the two sides of the gate come together and close, you have systole, so that's the squeezing of the heart. And when the gate opens up, you have diastole, or relaxation. So think about this side and this side coming together from either side and causing your systolic function, and then it moving back out and relaxing. And so you cause a problem in here, and you may get a squeezing problem or a relaxing problem, so a systolic or a diastolic function disorder. If you have abnormalities in the membrane up here, you're going to get a problem that's attached to the contractile apparatus, and you get a squeezing problem only. Or you could get arrhythmias because the arrhythmia parts of it, ion channels, live within the membrane. So those pathways are probably how the genes affect the function of the heart, because depending on which one of these proteins the gene is making and making poorly, that's going to be your central problem. So we could identify the central problem through genetics and through protein analysis, and that's what my lab and other labs do to try to figure out what causes the problem in a patient. And just as importantly, can we diagnose family members early so that they don't actually get into heart failure, they don't get into problems. We could treat them earlier and keep them out of problems so that they never need any more therapy than maybe a medicine or two, never get into the situation of having need for transplantation or have sudden death risks or that sort of thing. So that's really the reason for genetics, and also for developing therapies that target the problem. So this is another way of looking at these pathways. So this is the sarcomere here that we're showing. There's the parts of it that are parts of the membrane, so-called cytoskeleton. There's cell-cell contact, so two cells come together, they sort of glue themselves together. They glue themselves together through this thing called the desmosomes. Every cell has a nucleus, and that plays a role as well. And so dilated cardiomyopathy is a problem that's a combination of the cytoskeleton and the sarcomere. Hypertrophic cardiomyopathy is a problem of the sarcomere. Arrhythmogenic cardiomyopathy is a problem of the nucleus and of the cell membrane, and less of the sarcomere. So, and the desmosome is really the most key in that group as well. So we now have a feeling for what causes the different clinical features that differentiate one cardiomyopathy from another. And as I told you, there are 5 different types. And so some of them are problems that are primarily the sarcomere, and that'll turn out to be hypertrophic cardiomyopathy and restrictive cardiomyopathy. Some will be the cytoskeleton and the sarcomere, and that'll be dilated cardiomyopathy, and to some extent arrhythmogenic cardiomyopathy. And then left ventricular non-compaction sort of overlaps most of these. So it gets increasingly complicated as you start subdividing these disorders. So when you look at the underlying causes, what kind of disorders lead to dilated or hypertrophic cardiomyopathy, the two by far most common forms, we call those etiologies or causes of the disease. And you can see that hypertrophic cardiomyopathy, which is the dark lines here, primarily caused by inborn errors of metabolism, so enzyme dysfunction disorders, malformation syndromes, and in the case of dilated cardiomyopathy, that could be any number of syndromes, including some genetic-based and some chromosomal-based abnormalities. Less in the, and Noonan syndrome is common in hypertrophic. Neuromuscular disorders like Friedreich's ataxia. When you look at inborn errors of metabolism in dilated cardiomyopathy, much less common. Malformation syndrome is less common because Noonan syndrome is so important in the hypertrophic cardiomyopathy. but very prominent in neuromuscular disorders, because Duchenne, Becker muscular dystrophy, all of those have dilated cardiomyopathy, and they're pretty common. Myocarditis only causes dilated cardiomyopathy, and it's usually a virus. And then the sarcomere being affected in both familial dilated cardiomyopathy and hypertrophic, but more common in the hypertrophic side. So we were attaching some underlying diseases with the expected cardiomyopathy. This is how you get inborn errors of metabolism demonstrated here. And what you're seeing is the inside of the cell. So again, this is the cell membrane here. Here's the sarcomere, the contractile apparatus here, and lodged between it are mitochondria. Mitochondria are the power packs of the cell. They create the energy that's driving this. So if you think about this like we're driving a train in the old days when you used coal. So this is creating the coal to feed the engine. And the engine here are these things here, myosin binding, the myosin heavy chain, which requires this energy, this ATP created from the mitochondria. So it provides the ATP energy, and this is the coal, this is the engine that is going to then push the closure of the contractile apparatus. Those gates will close, and then when it uses up the energy, the gates will open. And so it's a feeder, and it sits right within the distance that it could very easily transmit its energy directly. So if you get a mitochondrial abnormality, you're going to shut down the system. If you get some other of these things like lysosomes, you're going to shut down the system. These are all required for normal metabolism, normal energy creation, and energy utilization. So it becomes a energy mismatch problem one way or another, and you'll end up with a problem with squeezing or relaxing, in this case, mostly squeezing, when it causes dilated cardiomyopathy. So dilated cardiomyopathy over the years has not been a friendly disease to have. When you look at from the 50s through 2000, we didn't do very well. We were in the 30 to 50% mortality at 30% or so at 1 year, 50% at 5 years, death rates in patients who have these problems. Now this is an adult figure. There really weren't very many data points for kids, but for decades we had a 50% 5-year survival rate in adult patients. From 2000 to now, it's declined significantly because of a better understanding of what the real problem is, which is mechanical forces, as I mentioned earlier. And so our therapy changed 180-degree opposite from the way we used to do it. We used to use medicines to make the heart pump, quote, better, where it actually was just pumping harder, to now when we are more interested in the efficiency of the heart. So we used to think power was important, and now we think efficiency. So it's the old story of the rabbit going fast and burning itself out versus the turtle going slow and can go forever. You want to be the turtle in this race with dilated cardiomyopathy. So up until 2000, very little improvement. Between 2000 and now, we've made some progress, and we're now tracking pediatric data, and the pediatric data is keeping pace or maybe even a little better than some of the adult data. So we're making some progress. So how do we treat patients today? So we use the turtle versus hare analogy, where we usually use medicines that make the heart relax better, and we use those same medicines will also reduce mechanical stress, because that's the problem. So we use things called ACE inhibitors, ACE inhibitors, and these are medicines that end in pril, so captopril, enalapril, lisinopril. These are drugs that are commonly used to fight against high blood pressure. So they lower the blood pressure. And they do some other things to help the heart muscles themselves relax. So we lower the blood pressure so that the heart isn't having to pump against a blood pressure that's way high, which it can't do very well because the mechanical forces against it are too stringent. And on top of it, we usually use a so-called beta blocker. And a beta blocker is sort of an anti-adrenaline type medicine. So what it does is it lowers blood pressure, but it also lowers heart rate. So the two contributing features of mechanical stress are addressed by the use of ACE inhibitors and beta blockers. Beta blockers are those medicines that end in olol, so propranolol, atenolol, metoprolol, sotalol. Those are all beta blockers. And so we'll use an ACE inhibitor like lisinopril, which is a once-a-day drug, with a beta blocker like carvedilol or metoprolol in dilated cardiomyopathy patients, lowering their heart rates, lowering the blood pressures, and letting the heart fix itself basically by not beating itself up. Some people also use spironolactone, which is also called aldactone. Along with these medications, there is some outcome improvements with the addition of aldactone or spironolactone on top of the ACE inhibitor beta blocker medicines. Sometimes in patients who have had heart failure, furosemide is also used. That's also called Lasix, and other medicines like it to make you pee more so that you get rid of all of the excess fluid that may be building up in your body. In the old days, people used digoxin plus Lasix as the therapy, and you had your 50% non-survival in that patient population. Some people still use it. I don't personally, but some people use it for whatever reason that they believe it does good things. A baby aspirin daily when there is a big chamber and poor systolic function. Reason for baby aspirin 81 milligrams is that it does a good job thinning out the blood a little bit because in big left ventricles that don't squeeze very well, the blood is pooling in there, not getting pushed out. It can start to clot. If you get a clot in the